And I'm so pleased to be joined by Dr. Cedric Jamie Rutland. He was just giving me life advice before we got started here, Dr. Rutland. Not only a doctor, but sort of a life coach, it sounds
Father.
like. And a fellow father, yes.
Father and a husband, I get it.
How old are your kids? I
got a 12-year-old and a 10-year-old.
Got it. All right, well, I have a lot of questions for you because my oldest and only right now is 20 months old. So we're still, we've achieved walking and now we're getting to the potty training stage of the game here.
Yeah, no, I get it, man. Trust me.
But in all seriousness, you are a specialist in pulmonary care, critical care, internal medicine, a lot of issues to get to. I put out a call to our community on Instagram, Dr. Rutland, and got hundreds of questions. So, folks, I can't get to all of your questions, but we will incorporate it into this conversation. Two big topics we really want to get into here is the cost of health insurance, what's behind that, any hope in the future about it going in a different direction, and then GLP-1s, effectively one of the hottest medications, if not the hottest right now in terms of
history.
In
history of the world.
Yeah, there's like Tylenol and GLP-1s.
Yeah, exactly.
Up there. I think you had an era in the 90s with Viagra. That like was sort of a thing too, right?
Yeah. Right. Exactly.
For those of you listening, he just gave me a look. For those of you not watching on YouTube. Yeah, definitely. But let's start here with your story a bit. I'd love to hear your background, your specialty, and what sorts of patients, what is a day in the life of Dr. Rutland these days?
God, what a great question. My story starts 15, 20 years ago when my grandfather died from a respiratory condition during my first year of medical school. I had written down in the 5th grade, because I went to my grandparents' house every day, that I wanted to be a doctor. And I was like, I'm either going to go to the MBA or I'm going to go be a doctor, right? And it's like, I didn't grow past 6'1". In first year of med school, grandfather died. So then, because he died of a respiratory condition, naturally, I became curious about the lungs. So I went into pulmonary and critical care. So I have 3 boards: pulmonary, critical care, internal medicine. And when I left fellowship and started clinical practice, I started in Southern California. I wanted to stay at an academic institution, but academic institutions don't pay very much. So I did private practice, and I've always been a teacher. So I wanted to always educate. And I was like, okay, how am I going to do that if I'm not an academic institution? So then I started doing a lot of educational consulting for the pharmaceutical industry on disease states. And when I started doing that, a little bit before that, I had started a YouTube channel where I started kind of explaining disease conditions, and that kind of grew a little bit. And then things just kind of started to snowball, and I started to educate more and more. And then I started to incorporate media, and then incorporated more media consulting and making educational videos for the pharmaceutical industry, the medical device industry, continuing medical educational companies. And now I do both clinical practice. I practice 2 days a week. I do autoimmune lung disease, immunodeficiencies, asthma, COPD. I do procedures a half a day a week. I do the intensive care unit 2 to 5 times a month at night. And then the rest of the time I spend creating the content, the educational decks, and all that for the healthcare industry. And I think that's served my purpose in life really, really well.
So, among the issues I imagine you get a lot is a question regarding the cost of coverage, insurance. There's a lot of just stunning stats out there. One that caught our attention: more than a third of Americans, about 90 million, say they couldn't afford the access to quality healthcare if they needed it today. Very significant. Let's start big picture here, Dr. Rutland. Why is health insurance so expensive? How did we get to this situation here in this country?
This is such a big question, but I think it's a question that deserves attention into investigating how we got here. When you look at the history of health insurance, right? And in the United States, it started kind of in the early 1900s, where what ended up happening is employers noticed that people were getting sick. And when people were getting sick, they couldn't work. And if they couldn't work, they couldn't make money to support their families. So they started these like employee funds, right, that everybody kind of dumped money into. So if somebody got sick, at least their family could eat. That kind of found its way into becoming paying for the patient's health plan, right? Blue Cross and Blue Shield were first. One represented hospitals. The other one represented the physicians. Physicians have kind of always fought health insurance over time because they wanted to be able to set their own price. When they provided a service, they wanted to be able to get paid of what they thought they were worth, so on and so forth. And then, while the rest of the world noticed that health insurance companies really shouldn't be for-profit companies because that's kind of a conflict of interest there, The United States just kind of allowed that to happen.
Right. The incentive structure is off if insurance companies are for profit, right? They're incentivized to keep people sick as much as possible.
Or charge them as much as possible when they are sick.
Right.
Right. And have the patient pay cash, even though they're supposed to cover them to a certain extent. So you've got rising healthcare costs. You've got the baby boomers, right, who are now reaching that advanced age where they're receiving a lot of care, right? And that's a significant amount of people. You've got different types of plans, different types of coverage. You've got HMOs, you've got PPOs, you've got all of these things. Then you have administrative costs in which the United States has decided, all right, insurance companies, you guys are allowed to have 20% of the cost be administrative. That's where your profit comes in, the salaries come in, but 80% has to go towards the health of the individual. And so if you look at other countries, it's like 5% or 3%, whereas the United States allows up to 20%. And so again, you have these insurance companies making a significant salary, right? And they're reporting significant dividends for their investors. And I think that we get lost in all of that, and that all adds to the cost. And then you have significant third parties adding to this cost. You've got pharmaceutical companies charging a lot of money for drugs. This I kind of understand because they invest a lot of money to develop certain therapies for years and years and years, billions of dollars. I understand wanting to get that money back and make a little profit off that development. I'm cool with that. What I don't quite understand is how these third-party companies in between, the pharmacy benefit managers, how they can charge insurers more to get their drug on formulary and then not give the money back to the patients, just take all of the money as profit. Again, some of these things just need to be regulated a little bit to bring down that cost. But I also think from a patient perspective, I think we got to pay attention to things, right? I think we got to understand that when you have a McDonald's on every corner in low income areas, this is the type of food that people are going to eat, which contributes to a health problem, right? You've got an obesity problem, you've got metabolic syndrome, which includes diabetes. So it's a very complicated question that deserves investigation and deserves to be broken down in ways in which, how do we make the country healthier, which is going to reduce the cost of care overall, right? And I just feel like we have to be better at doing that.
You got to a lot there, including mentioning pharmacy benefit managers, because I think a lot of people are unfamiliar with the fact that you have the drug companies, you have the pharmacies at the other end, and in between, you have the insurance companies, you have the pharmacy benefit managers. I mean, there's a whole train of organizations, people, industries from the point of producing those drugs to you getting that prescription.
A whole train. And so what pharmacy benefit managers are, and it's very, very difficult to explain, is what happened a long time ago is insurance companies said, we don't want to basically waste our time trying to figure out all of the drug products, how much they're going to cost. We need somebody to help us. So first they were like a part of insurance companies, and then they kind of evolved to their own thing. And so what they basically do is they talk to the pharmaceutical company and they say, how much is this going to cost? They talk to the insurance company and then say, okay, how much are you going to pay for this product? And then they're negotiating this on both ends. And then what they're doing is they're making money basically off of that negotiation. And so that has evolved over time to being a huge business because these pharmacy benefit managers control 80% of the US market. There's three of them that control 80% of the US market of prescription drugs, right? CVS, Caremark, Express Scripts, which is Cigna, and then Optum RX. And so you have these companies, they also have their own insurance plans. And so it's a giant, I don't want to say it's a mess, because I think it can be fixed. But I think what they're doing is they're taking advantage of the money that's out there and they're keeping the profit instead of redistributing that profit towards healthcare, which I think patients deserve some of that.
I mean, one of the questions I got, people want it simplified, right? Who's the bad guy? Who's the good guy? Who am I rooting for here? But it sounds like there's a whole gray area here. There's not like, this is the one bad thing. It's the system writ large.
It's interesting. When you look at health systems across the world, there is no perfect health system, despite what you think. So if you look at the United States health system, here's the thing that I'll say. I'm a physician, right? Doctors can do very, very well. It's a nice, high-paying wage job for individuals that spent $300,000-$400,000 to go to medical school. They finish medical school, and when they get out, they're going to get a pretty decently high paying wage job. I think that's excellent. I think that that's great for physicians in the United States. When you look at physicians in England, they make a quarter, right, of what we make in the United States. But they also provide health care for all of the citizens of that country, right? They get health care. They're going to be able to be taken care of. But that health care is also limited. There's certain drugs, there's certain products that they can receive. They can buy extra insurance from private places if they would like, but everybody kind of gets this baseline health care. Also over there, the kids aren't paying for their schooling. Like the medical school and all of that is not a significant cost.
They have a very different approach on taxes in those countries in terms of how much you pay, but also what it goes to. And I should note, having spoken to Canadians and people from other countries, one of the issues they have also is that like you might get healthcare, but you might be waiting a very long time to go see a specialist.
100%, right? Yeah. And so a lot of the people, when they get really sick, they end up coming to the United States. And so the system, it's not the greatest system because of how much it costs. But again, there are some aspects of it that can be good. And it needs to completely break down before somebody can go and rebuild the system. But it requires a lot of change.
I was in Washington as the Affordable Health Care Act was being negotiated on Capitol Hill, what's known as Obamacare. And they had very high hopes for that. Where are we kind of like a decade later? Because they've pulled back certain parts of that program. Are we net, like, has that helped? Has that hurt? Is it net neutral at this point? Are you able to give me sort of a comparative of what things were like before that and what they are today?
Yeah, I mean, other than like Medicare, right? The Affordable Care Act was probably one of the single greatest laws that has been created by that administration in the health industry. And the reason I say that is because it provided health insurance for a significant number of individuals that did not have it, right? And what that did is it allowed these individuals access into the industry of healthcare and what it meant to be taken care of medically for certain chronic conditions, really any conditions. And I think that that is great. In terms of the cutbacks on some of the, amendments or on some of the processes that need to take place within the Affordable Health Care Act, it's not great. It's not a perfect document, but I think that overall, it's a net positive. I know individuals have to pay for their healthcare, but it's appropriate. I don't know what it is about individuals that thinks that healthcare should be absolutely free of charge, so to speak. Right. I do think that, you have to pay for certain things in life. I do think that paying for some of your care, I think that that's appropriate. And I'm a physician and I know that I can afford it, but my wife recently went through breast cancer and she had it twice. And I remember walking up one day, she was going to have a mastectomy. And I walked into the hospital for her to have her mastectomy, stopped at the administration desk, and they asked for a $3,700 payment right then and there. Fine, like no problem for me. I had no issue with it. Yes, I could afford it, but I also understood that it was a percentage of what was going to be, her extensive hospital stay due to her due to her condition. So I'm on both ends I'm on both ends here. I've been there as a patient. I've been there as a provider. I've been there as a husband and as a father.
So as far as insurance companies, though, I mean, one of the big issues people have with it is the denials, and some of them are using AI now to deny coverage. One of the questions we got from a member of the community is, after repeated denials, like what is my recourse? What should I be doing? And can you speak to sort of the rationale, or sometimes the lack of rationale, behind some of these denials that seem like they should be covered by insurance companies that we're paying a lot of money to?
Right. So this is something that I deal with every single day, right? So as a physician owner and owner of my own practice, when I see a patient in the hospital or if I see an outpatient, I have to write a clinical note. My clinical note has to incorporate ICD-10 codes, which is essentially what justifies how much I can charge the patient for the visit, essentially. So say I write down asthma, I write down eosinophilic asthma, and then I say something like patient needs inhalers, patient needs this medication, right? So I order the medication has to go to their insurance, and then their insurance looks at the medication cost, looks at their ICD-10 code and will say, this ICD-10 code isn't good enough. You have to rewrite your note, or they won't even say that. They'll just say, we're not paying for it, right? And the same thing that happens on the patient end. And basically, I don't want to say it's the doctor's fault, but if something's not being covered, either that patient didn't know that it wasn't covered in their plan, which can be an issue, and nobody knows everything about their plan. B, the physician's at fault because they didn't write the note well enough for the insurance plan to understand what is going on and understand the FDA indication for said product. So I think that what has to take place is a conversation between patient and physician, and the physician understanding that plan. I have an office manager who's worked in my office, because I share an office with 3 other primary care providers, worked in my office for 45 years. She knows insurance plans backwards and forwards, what they'll pay for, how they'll pay for it, what I have to put in my note to make sure that things do get paid for. She is a godsend in my office. And so having her next to me allows me to be successful in terms of my patients aren't getting those letters that you refer to. But I can say that those letters are based on justifying paying for a certain product based on the disease state that you have. And that is your physician.
So in some cases, what your suggestion is to folks when they get denials is to go back to their doctor and say, hey, like, can you, approach it differently in terms of your next request to the insurance company?
Yeah. How, what can we do different? Now, again, some of the physicians that come out, I didn't learn any of this in medical school. I didn't learn any of this. I had to learn all of this on my own afterwards, right? The business of medicine. When you are a young kid and you just finished residency and you go work for a system, you just do the work for the system. They're responsible for collecting the money. If you go out on your own, you're going to get a lot more of this. What you didn't know is behind the scenes, all of your support staff was helping you with this, adding things to your note, adding diagnoses that you meant to add that you just didn't quite add to make sure that things can go along and become smooth so that insurance companies are doing what they're supposed to do, which is take care of patients.
I've noticed different price differences between different insurance providers, different packages, et cetera. What's behind that too? How two different insurance companies can have completely different, percentage of what they cover, cost?
That's completely random. So insurance companies will decide what they're going to.
There's your answer, everybody. It's completely random. Yeah,
it's completely random. It's so funny. Like there are certain insurance plans. They're going to pay you X amount of dollars. So I do a procedure called bronchoscopy. It's a little video scope I put in the lung, squirt fluid in, biopsy the lung, all kinds of things. Insurance plans pay differently for that procedure. Each plan pays differently. You hope that it's based on Medicare. Sometimes it's 20% greater than the Medicare reimbursement rate, so on and so forth. It just depends, but it's completely random, right? And it's based upon negotiations with certain physician groups in the area. So like, say I have a physician group that represents all of Southern California and we're all one group, and we go to Cigna and we say, we're not going to see any of your patients, but Cigna doesn't have a choice because we're the only doctors in Southern California. I have more negotiating power and I can increase my rate of reimbursement for certain procedures, right? But with these insurance plans, like sometimes I notice that Dr. Smith, 4 blocks away from me, gets paid, $50 more than I do, right? For the same thing. And again, it's just completely random. And that's part of the problem with the industry. The reason I love Medicare so much is because it's all written out for me. I know what I'm going to get paid for doing X, Y, Z. That's why I love it. I know what I'm going to get. It's completely random. That's all I can say.
Got it. By the way, I got one question here, and I've actually always been curious about this. Do you know why medical and dental insurance are separate?
I have no idea, but I'll tell you this.
Yeah.
Dentists are like the smartest people in all of healthcare. Like they figured it out long ago, right? My daughter went to the dentist last week for braces and they said, this is what it's going to cost. This is cash cost, blah, blah, blah. Done. End of story. Had to pay cash. That's it. I have no idea. It's the same thing for ophthalmology now. Ophthalmology insurance is different too, right? And optical insurance is different as well. I don't know how they did that, and I don't know the history of that, but that's a great question. That's actually something that I'm going to look up, and I promise you, I will probably talk about it later today on my social platforms.
Okay, great. But I will share it with everybody. Thank you for doing the work for us, Dr. Jamie. One of the things that we're focused on here is we're partners with BuzzRx, as you are as well. is how all of this is impacting the price of drugs and what it means for what you're prescribing, whether there's generics available. How is the kind of evolving health insurance industry impacting that aspect of what you do?
Yeah. So when you look at online pharmacies, especially BuzzRx, right? The reason I like BuzzRx is because what BuzzRx essentially does is it gives you a discount card. And when it gives you a discount card, it basically pulls all of the patients that use this discount card. They'll go to a pharmacy, they'll present the discount card, and they'll say, hey, listen, this is my BuzzRx discount card. I need albuterol. And it will significantly lower the cost of albuterol, sometimes up to 80% in certain pharmacies, right? And it makes a significant difference in terms of cost. I use it a lot for my cash patients. I use it a lot for certain medications in which I know that their plans are going to charge them a significant amount of money. So I just have them pay cash, knowing that BuzzRx is going to lower that cost for them significantly. So this is why I like online pharmacies like BuzzRx. It's BuzzRx, and you can go to the website BuzzRx.com. And what it'll do there is you can actually search for the drug, the generic drug, or any drug, really even the brand name drug, and you can see the amount of discount that you'll receive depending on if you're at Walgreens or CVS or wherever you pick up the product. So I really, really like that because it does give us some sense of control.
Yeah, I have the BuzzRx app, so you can easily search various meds there. Are there specific medications or conditions where you're seeing some of the most savings right now?
Yeah, I would say in hyperlipidemia, high cholesterol type of drugs, you're going to see significant savings. Asthma drugs, you're going to see significant savings. I know the asthma guidelines in terms of management have changed recently, but you're going to see significant savings on albuterol and inhaled corticosteroids, which you have to take together when you're having symptoms. Diabetes as well, you'll see significant savings on those products. So common clinical conditions that people or that physicians see on an everyday basis that I see in the hospital, COPD, asthma, diabetes, high cholesterol, hypertension, that's where you're going to see the most savings.
That takes us to our next section here, GLP-1s. First, just sort of remaining question, BuzzRx and GLP-1s, impact there on the prices?
Yeah, so there is a significant reduction in the prices for GLP-1s, right? So when you look at BuzzRx and their impact on pricing, they can get the GLP-1s for 15 to 20% less than their cost, which I think is very significant. So BuzzRx does have GLP-1s available, and they do have the ability to lower that cost significantly.
All right, so while we're talking about GLP-1s, we're talking Ozempic, Wegovy, Mounjaro. The buzz. I mean, it felt like less than a decade ago, you're like, wait, how are these people losing this weight, right? And it was sort of, there was a stigma around it, and then sort of mostly everyone has come clean with it. Seems like it's okay now. Oprah was probably one of the people that, like, when she went public with the fact that she was using it, that made a significant impact. How much of a game changer is the discovery that GLP-1s have an impact on weight loss had in this country and around the world right now?
It's a huge game changer. We know in the United States, we have a serious problem with obesity. Obesity leads to the metabolic syndrome. So you have a reduction in your insulin sensitivity. Your adipose tissue leads to more inflammation within your body. You develop obstructive sleep apnea, which can lead to significant heart failure. So you have all of these things as a result of the weight gain, which is really as a result of the food that's most prominent in this country, but that's a story for another day. But when you look at GLP-1s, I was one of the people that said, oh, dude, you can do it yourself. All you got to do is run and lift weights and you can do it yourself. I think it's, I didn't think it was very smart to do that. Like, there are effects associated with them. Like, no, you can't do that. But then, I'm one of those guys. I'm a little bit of a nerd. I'm a little bit of a geek. And I was like, let me look into this. So you look into the mechanism of action of this product. And not only do the GLP-1s increase insulin secretion, and not only do they tell your hypothalamus that you're not hungry, so they reduce the amount of food that you intake, which leads to weight loss, by the way.
Right. It's like literally rewiring your brain, rewiring your body.
It tells your body that you're full, right? It slows down your GI tract even. It slows down the contractility of the muscles that control your GI tract, pushing things down the line. So you feel more full, right? And when you feel more full, you don't eat. And that's why you lose weight, because you're not eating the calories, right? And for those individuals that participate in exercise, you're going to burn even more calories. But here's the other thing that it does is, because of the presence of that GLP receptor. It's not just present in your central nervous system. It's not just present on your fat cells. It's present all over your body, on some of your immune cells. It actually reduces inflammation in your body. It reduces the products that lead to significant inflammation. It helps with joint disease, osteoarthritis, helps with autoimmune disease, rheumatoid arthritis. It helps with neurovascular diseases and cognitive diseases like Alzheimer's, dementia, Parkinson's disease. All of these fantastic discoveries secondary to understanding the mechanism of GLP-1s, which is why now I am more of a proponent for them. If a patient wants it, I got no problem with it. I will prescribe it. I will get it for them. I will get it to them because I understand the positive mechanism of the action of these products. And I think it's very, very important. I know people just want to lose weight. I get it. Like, you're going to lose pounds on the medication. I know that's the attractive thing about it. I get it. No problem. No issue. But there's a lot more attraction now because of understanding that mechanism of autoimmune disease and how it can impact autoimmune disease and how it impacts the metabolic syndrome overall.
You sort of alluded to it in terms of your evolution on GLP-1s, but curious, this is one of the questions that we got, which is, should they be used as a first or last resort for stubborn weight?
I used to be, okay, it's a last resort. Now I've kind of evolved. I'm like, all right, if you want to lose some weight and you want to start exercising, I'm cool with it. Let's do it. Let's try it out. Let's do it. Now we have to understand that there are effects of the medication.
Yeah, let's talk side effects here.
Yeah, there's a common term that I'm not necessarily the biggest fan of the word side effect, because side effects are effects secondary to the mechanism of the product. So it's not a side effect. It's an actual effect of the product and how it works. So people can develop nausea and vomiting. Well, you're slowing down the GI tract. So of course you're going to develop nausea and vomiting. So what I tell my patients is, I'm like, listen, the day you take your shot, especially if it's for the first time, don't eat anything. Like, try not to eat. Try to eat very, very little so you don't have that nausea and so you don't vomit, right? It can slow down your GI tract so much that it can basically simulate a bowel obstruction, right? This can happen. So you want to be careful with that as well. And that's not something that you can specifically control per se, but you have to understand that if you're feeling bloated and if you haven't had a bowel movement in a few days, you could be obstructed. So you might need to seek medical attention. These are the major side effects of those medications, but they're all effects secondary to how they work.
Another popular question we got from a number of people, long-term, what happens in 10 years? This seems too good to be true. Risk factors and sort of the calculation of, the benefits of losing weight versus, again, I won't use the word side effects, but effects of the medication. What do we know? And are there studies out there in terms of long-term? Because, obviously using it for weight loss is a relatively new phenomenon.
Yeah, so there hasn't been anything new over the course of the initial studies, but again, it's only probably been about 8 or 10 years. So you want to see over the course of time. So we're going to learn more and more information. The way that I use them in my clinical practice is, I'm not a guy that puts somebody on Ozempic or Mounjaro or whatever and just says, all right, you're on it forever. I'm a guy and I say, like, hey, let's use this for 3 months or so, lose some weight, and then I want you off of it for a bit. Let's see how you do on your own. Let's see how you do exercising and with those diet changes and lifting weights, resistance training, and let's see how you do and keep you off of it. And then if you want to go back on it for a little bit, you go back on it.
So for you, a combo is super important, that in addition to taking that, you got to be eating healthier and you got to be working out.
I look at it as a reset. Like, okay, hey, listen, you're not as hungry, but when you are eating, why don't we put something else in your stomach? Instead of going to McDonald's to get the Big Mac or whatever it is, why don't we get a healthy stream of what's in the produce section along with some clean protein, right? If you're going to start Ozempic, why don't we go to a nutritionist and figure out what kinds of things we should be putting in our body? It's kind of an educational opportunity.
In terms of how much weight somebody can lose, what have you seen? What is sort of the average in terms of how much, or as a percentage of their BMI or overall fat situation, are you seeing it impact?
Yeah, when you look at semaglutide, right, which is the most popular one, that's Ozempic or Wegovy, people are going to get like a 15% weight loss. So they're going to lose 15% of their body weight over the course of about a year or so. I have seen even more, right, of a weight loss. And I'm not going to lie to you. I was the heaviest I had ever been in my life, maybe a year and a half ago. I was like 190 pounds, which is like not me. It was like a really like busy time in my life. I tried it once. I lost 17 pounds
When you
in
say
like a
tried it
week.
once, you mean you literally did one injection?
I did one injection. I lost 17 pounds. It was
Wow.
crazy. And I had all those side effects like nausea, vomiting. I didn't
Yeah.
understand it like I understand it now. It was crazy how much weight I lost. One of the reasons I tried it, number one, yeah, I wanted to lose some pounds. But number two was all my patients were telling me all these things and I kind of wanted to be able to talk about it. And so now I just tell them, I'm like, listen, I took it. This is what I think you should do. Try it out, see if it works for you.
Yeah.
Use it as a reset. So I find it extremely helpful. I've seen patients lose 100 pounds over the course of 24 to 48 weeks, right? These are patients that are super motivated. These are patients that take the opportunity as I'm not just going to take this drug. I'm going to take this drug and I'm going to change my lifestyle. But I've seen it done.
Question for you, because you mentioned the whole like try it out. I want you to get, try it for a few months and then get off of it. What impact does that have? Sort of like taking it, not taking it? How much, to what extent have you seen people who are taking it, see weight loss, get off of it, the weight comes back? Do you see that pendulum swing, or does it have a relatively, I wouldn't say permanent, but long-term impact on people's weight and health?
The only thing that's permanent is the habit that you develop. So what I look at it as an opportunity to develop a new habit. So when you're on it, let's develop a new habit. Let's keep up the habit when you're off of it. I don't like people being on medicines for too long if they don't have to be. It's just how I practice medicine in general. So again, the people that are the most successful, that keep the weight off, are the people that completely changed their lifestyle. Individuals that didn't change their lifestyle, the weight comes back on, we put them back on it, same thing, and it's kind of a cyclical thing. I got no issue with that, really, because I know that we're keeping the patient healthier overall. They have lost their weight. They don't have obstructive sleep apnea anymore. They don't have type 2 diabetes anymore. They've reduced their systemic inflammation, which has led to less joint pain, so they're able to go on walks and enjoy life. So again, there's too many positives being on it for me not to use it.
At the same time, I've heard anecdotes from some doctors that like they have parents coming to them, and I'm curious about this, the under 18 set. They had parents, literally, I talked to one doctor who's like, yeah, one parent came to me saying my daughter really wants to lose a few pounds before prom. And so it's the use cases like that where people are like, well, is there abuse of that sort of drug right now? Where do you come down on the use of these for kids?
That I don't like. I don't like kids, especially kids that don't have that abnormal BMI, that BMI over 25, saying I want to lose a few pounds. Like, I'm all for you wanting to be in shape and wanting to do the right thing, but I don't want to give you a product that could potentially give you a side effect like bowel obstruction just so you can lose a couple pounds before prom. I don't agree with that. I'm talking about, and again, at the time when I was 190 pounds, my BMI was over 25. So I'm talking about individuals who have that BMI over 25, which increases their mortality and can lead to things like type 2 diabetes, and using it in those folks. I'm not talking about, and I know Hollywood does it all the time for roles, different thing. You're getting paid for a role. You got to play this role. Like, I get it, but I wouldn't give it to kids like that.
Yeah, I know there's been a whole debate about that, especially as we sort of have entered this MAHA phase, Make America Healthy Again, dealing with childhood obesity and where, we should land on diet, exercise for kids before we start to introduce medications.
Childhood obesity is a different story. Like, I would have no issue with it if a child was obese. Because again, like, you got a 9-year-old that's obese that probably is getting made fun of at school. It's affecting their self-esteem. It's affecting their confidence in life. It's affecting their ability to want to participate in life. That's an entirely different story. And because I've seen it change people in a very positive way. And so I can't deny that child that opportunity in that sense. I'm talking about the kid whose BMI is 18 that, wants to fit into some ridiculous Barbie dress and wants to use it. That's taking advantage. Childhood obesity is a different story. But I think that as long as that comes with education, not only for the child, but for the parents that are feeding that child, I think that's where it's important.
Yeah, and I wanted to get, before we go, to what's next on GLP-1s, because we continue to see stories about innovation, about the pill form of it. What are you most excited about as you track them?
So the pill form of it is already available. It's called Rybelsus or something. It's already available. You can get the pill form of it. I don't know if it's as effective as the subcutaneous, the shot form of it. So there's that. When you look at GLP-1s, there's also other molecules that we want to agonize. So there's a receptor called GIPR. There's another receptor called the glucagon receptor. And what they're doing is they're combining all of these molecules together. And you're getting, instead of dual agonists, like tirzepatide activates two of those receptors, GIP and GLP. You're getting triple agonists, which activate all three of the receptors to make the disease state or the receptor even more efficacious, right? And so you get such a profound effect from all of these molecules together. And I think for me, the weight loss thing is great, but I think for me, the inflammatory cascade is even more profound because there are a significant number of inflammatory diseases of the brain, of the body, that contribute to morbidity and mortality in this country. And if something like semaglutide is going to not only lead to weight loss, but also a reduction in inflammation and a reduction in pain, which we've seen in the medical literature, then I think that this is an excellent option for those patients. Again, my clinic, I'm very biased, is all autoimmune lung disease. So I've got a significant number of autoimmune lung disease patients who also happen to be obese. Right. And so again, if I can get a twofer, if I can reduce their inflammation and reduce their weight, which I know is going to lead to them being able to exercise more and do more things and feel more confident, I'm happy.
I also saw, and you mentioned it briefly, we got a question about this, is its impact on GLP-1s on sleep apnea and dementia.
Yeah. So when you look specifically at dementia, so Alzheimer's disease and Parkinson's disease, a lot of the molecules that are responsible for some of the inflammatory cascade that leads to worsening dementia and worsening cognition, those get downregulated in the presence of the GLP agonist. And so if you downregulate those molecules, you're treating that dementia as well. And these patients have higher cognition rates, right? We've seen it in mouse. We're starting to see it in human beings. There's big trials there that are out there because there's no cure for those diseases. But if you can manage those diseases better with these products, it's a great opportunity there. From a sleep apnea perspective, the reason it treats sleep apnea is because the number one risk factor for obstructive sleep apnea, which is by definition the amount of times your oxygen saturation is less than 88% on room air when you're sleeping, you're losing the number one risk factor is weight, a BMI over 25. And so when you lose that weight and you drop that weight, you drop that adipose tissue, you're going to reduce the number of apneic events in that hour, which reduces sleep apnea overall. So this is why it got approved for sleep apnea. It's because of that weight loss.
A lot of helpful information there, Doc. I appreciate you joining us to explain all things health insurance and GLP-1s. Anything else top of mind before we go here?
I just want people to go out there and find a way to obtain health insurance. I know it's expensive. I get it. It's very beneficial. You get involved, you get taken care of. I really think that that's important.
Yeah, because there's a point in your life, especially when you're in your 20s and 30s, where you're like, I don't need this stuff, right? Like I'll save the money. Any I won't say horror stories, but any warnings to folks who have that mindset?
I have seen 25-year-olds suffer from septic shock, which is extreme amount of inflammation in the body secondary to an infection for no reason. People get sick. It's a very random thing. It's not 100% guaranteed that you're never going to need a physician because you're 25 or 30. Yeah, you're less likely, but you never know, right? If your mom or your dad has a chronic condition, you're at risk of developing that chronic condition. If your mom or dad has asthma, you probably are going to have asthma at some point in your life. So think about those things. And when your job offers you insurance, take it. I think it's very important for you. So I just don't agree with, just because I'm 25 means that I'm invincible. You're not. Things can happen.
Dr. Rutland, thanks for joining us.
Hey, thanks, Mosheh. I appreciate it.